Welcome, and I'm going to start the first lecture, which is on coronary anatomy, physiology, and imaging. So that's what I'll be going over, some of the theory, and then a couple of questions also will be discussed. So going over the anatomy, which is here, simple basic anatomy that we have to talk on, okay, which is a left main, of course, all the arteries on the left side, LAD, circumflex, and the right coronary artery. So if you see there, you can see the left main coming off and then LAD going all the way to the apex. And how do you know it's LAD? Most often you will see the artery that will be bifurcating, called the inverted mustache sign at the apex, and the branches, diagonal, septal, and then you have circumflex that comes out of the left main and posterior. Okay, so it is the posterior vessel once it comes off the left main. So on the right side, if you see on the, it's only right coronary artery that comes all the way, goes back to the crux, and at the crux it gives the major artery, which is the PDA. So depending where the PDA is originating, you will define whether the patient has a left dominant or the right dominant. So we would say about 90% is left dominant, the other 10% will be uh, 90% right dominant, left dominant is 10, and sometimes you will see some co-dominance where you see PDA from both the side. So if you see the length of the left main, why do we need to know the length of the left main? Okay, one, it's originating. Most often when you're engaging, you can have trouble. So when I say 0, in few percent of the cases, which is anatomical variant, not an anatomical anomaly, that left main is non-existing, LAD is anterior and upward, and then you have circumflex, which is inferior and posterior. So in that situation, your catheter, the catheter that you choose to engage will be different. So if you take JL, this is all femoral approach right now, JL4O, and you're engaging into LAD, okay, you have to counterclock, okay, if you see there, counterclock will take you anterior, okay, clock will take you posterior, will take you, counterclock will be anterior, clock will be posterior. So when you do counterclock, you will either go anterior. So if you have to engage the circumflex, you will need a larger catheter because it is inferior and down. So remember that, okay? Very, very important that you have separate origin. If the catheter engages into the LAD, what is the catheter that you will use to get into circumflex? Often the question is asked. So optimal view, if you see there aleocaudal, you will see what? Left main, body, distal left main. So you want to see distal left main, aleocaudal is the best, proximal circumflex, LAD and proximal circumflex. And what is a LAD basic anatomy? I already said it goes down and out and goes all the way to the apex, about 45-55% of the left ventricle. Most common artery involved when you have STEMI, proximal LAD occlusion could go into cardiac shock. So epicranial, aleocranial. Often is AP or sometimes even RAO depending on the body habitus to see the LAD, which is proximal, is before the septal. People also can say the proximal LAD could be before the first diagonal, but you see how the vessel goes all the way down. Then you have circumflex, which I just mentioned. It is going all the way. So if you have to see circumflex well, caudal. So cranial view is LAD, caudal view is always circumflex. So you can go aleocaudal, apicaudal, RAocaudal. Whatever it is, you will see the circumflex vessel. So when this comes out, the first branch of the circumflex is obtuse, OM branch. So if you have the proximal circ is from the origin of the left main to OM, and after that becomes distal circ that goes down in the AV groove, and then you have OM2, LPL, very rarely you will have LPDA. So smaller part of the myocardium. Then you have the RCA, which supplies, I would say, about 25-30% of the myocardium. So you can see the proximal RCA there. And what is important is RV branch. So RV branch separates from the origin of the RCA to the RV branch is the proximal RCA. If there is occlusion of the RCA during acute MI proximal before the RV branch, that's when the patient can go into cardiogenic shock because of the RV occlusion. Okay, very important. So you will need, if you're seeing somebody, which nowadays there's no time, they barely do even an EKG in the ER now. So if they do an EKG, there is inferior rest elevation. By right, you should always do an RV lead to be seen, anterior leads to see if there is RV involvement or no. Because invariably these patients will go into, there'll be hypotension. Treatment is different, where you have to give fluids and not give nitro. So some of the questions here which you guys can answer is LAO 60, caudal 25. What is the likely, what are you going to see in that view? LAO caudal, C, right? Good. What about RAO cranial? Cranial, I said cranial should be for what? A, LAD. Remember, cranial is LAD. Very important. Good. Then RAO caudal. Caudal is what? Circ. So D. Then this is another LAO cranial. B, because distal RCA bifurcation. When is this important? Suppose you have RCA occlusion and you want to see the distal RCA collaterals, you have to do LAO cranial, and that also is an important view if you are planning to do a CTO intervention of the right coronary artery, that you know there's a good collaterals, can the vessel be done or no. Now, what is the spider view? Yeah, the one that I showed is the spider view, where you see left main, prox LAD and proximal circumflex. So it is LAO, which is that? D. That's the one. You see that? Often they will ask that. This one I already told you. This is not just for the question for the boards, but this is also important for your practical work. Okay? What will take you anterior? What will take you posterior? Movements of the catheter. Yes, remember that, okay? Counter clock will be anterior and clock is posterior. So if you heard that. So a catheter with a larger curve is useful in selectively engaging LAD in this setting. Is that is that true or false? False. What is a catheter you need? Smaller. Remember I said it is higher up, smaller. Circ is larger and goes down. So you need a larger for the circumflex. Okay. This one I did not say. So first branch of the right coronary artery is what? Good. So no, conus. Okay. So if you have a conus is the first. The conus often goes anterior and supplies the septal of the, through the septal of the LAD. And what is that collateral called? Circle of Usens. Okay. The second is sinoatrial. So sinoatrial branch is the one that will supply the sinus node, and majority is 60%. The rest 40 is coming from the circumflex. Okay. So that is individual sinoatrial is circumflex is 40%, 60% is from the RCA. So either way you have to get it right. Remember that RCA 60%, circumflex 40%. You'll also get, I think, get the questions to take home. So we'll learn that. I did not mention Kugel's. Anybody knows what is Kugel's collateral? I mentioned, right to right collateral, proximal to distal. Okay. So I just mentioned what was the second branch? Sinoatrial. So a part goes to sinus node, the atrial branch comes down into the atrium. And then you have the AV nodal branch from the AV continuation of the RCA, and that collateral is the Kugel's artery, that is AV nodal, very important. That they ask, and sometimes they even show you the angiogram, okay? Occlusion of the mid-RC and this connection, they'll ask, okay, what is this artery? A question can be formed around that area. Anybody knows what this is? Yeah. So when you have, what is the anomalous circumflex? So what I told you is anatomical variant when the left vein is absent. So anomalous circumflex is the circumflex coming from the right side. So it could be below the right coronary artery or from the right coronary artery. Either way, it has to go posterior. You have the aorta, it has to go posterior to the aorta to reach the ventricle in the back. So that's why you will see like a nipple sign. Okay, what you see, button, nipple, whatever it is called. So this can come in cardiology boards, this can come in interventional boards. Either way, both you have to know. And that is the commonest anomaly that also you need to remember. Okay, the circumflex coming from the right side of the various anomaly that you have. So what about the physiology? Let's go to the next. So this is a very hot topic. There'll be a lot of questions because of the recent development of microvascular assessment. So epicardial assessment, fractional flow reserve, there is a instantaneous fractional reserve and RFR, then your microvascular, which is CFR and IMR. So you have to go one by one. So if you see there in the epicardial, if you have a lesion, if you are talking between the lesion is the FFR, you see the epicardial. Then your pre-arterial or arteriolar and capillary. So all that will become the microvascular, okay? So this is where we are talking epicardial. So let's go about what is the epicardial. So FFR means measuring the difference of the blood pressure across the coronary arteries. You see that the lesion? So you have the proximal, which is at the guide aorta, and the transducer is at the tip of the wire. So distal. So that is how you get the pressure difference, PDPA. Okay, that's what the pressure difference has to be. And one good important thing is maximal hyperemia, because when you cause when you have a lesion, what happens to that area? That never responds to any kind of a hyperemia. So that actually accentuates. The lesion becomes tighter because the rest of the area will dilate. That is why that's important. So the number you need to know is 0.80. Okay, anything less than 0.80 is significant. Above 0.80 is 0.80 and less is significant. Anything above, which is 0.8. Okay, good. So then other one is what? Instantaneous flow reserve and resting full cycle ratio. So you have to remember what happens here is in the diastole. See the diastole, right? So when they are doing IFR, they will take the 25% of the diastole, which is way further down. That percent is IFR, and RFR is at one spot, at one given spot. But they will take 3 to 5 cycles and then they will give you a number. Here, you don't need to give any adenosine. So what is the side effect of the adenosine? Huh? Yeah, cough and other thing also. If people are have asthma and all that, can you give it? You cannot, right? So that is where those numbers are, you have to remember. So what is the number for IFR and RFR? Yeah. So big difference, okay? When they're asking you the question, you have to be careful what they're doing. And then microvascular is what? Way further down. Pre-arteriolar, arteriolar, and capillary. And those are CFR and IMR, and will tell you exactly where it works. So flow at rest versus hyperemia is CFR, and the resistance is the IMR. Now, do you know how to calculate these things? And the number CFR is what? 20. Anything above 20 is significant. Same way, IMR, anything above 25 is significant. So there is special wire for this. Okay, the company that makes that wire, And then there are sensors. So you have to do resting where you will give room temperature saline, okay, and then you cause hyperemia and then again you inject saline, and then it will calculate the time it has taken for that saline to be traveled from the proximal to the distal sensor, and it will automatically give you CFR and IMR. So this is where all the new terminologies have come from, where epicardial vessels are normal, non-obstructive, and then if there's ongoing symptoms, could be angina, could be positive stress test. So your positive stress test, normal coronaries, ongoing symptoms, that is where you're saying, okay, is this positive and do we need something done for the patient? So expensive tests have to be done to come to a diagnosis, and then you do the same thing, you calcium blockers. So if you see here the current guidelines, there's a lot of this which you can go through, and I think also Dr. Sweeney will be talking about it, where currently the guidelines are saying that when do you have to do it is 2A, not class 1 indication yet, but 2A for ongoing angina and doing all these tests in the cath lab. So 60-year-old male, 6 weeks after transmural infarction, having akinesis of the inferior wall segment on the echocardiogram, 85% of residual strength. So what is the problem with this guy? He has 85% residual stenosis. Should it be done or no? Why? Yeah. So CFR is positive, right? Anything less than 2O is positive. But that area is dead. So don't do anything because FFR is 0.88. And most of the studies are what? The survival as well as mortality benefit is only when you're FFR positive and you take care of the lesion. So here you don't need to do anything. Give him some kind of medication, extensive necrosis and little viability. Very important. Also, what you have to do is for the boards, most often you have to do conservative management, okay? Stenting is not an indication. So now patient has class 2 symptoms, okay? Class 2 symptoms, has an osteal lesion. So what test would you like to do? IVUS, FFR, CFR? I mean, myocardial should have been done before. If they did not and come to the cath lab because of the symptoms, class 2 angina, often nobody's on medication, right? What would you want to do? Has to be FFR, no? Yeah. Good. Which of the following values not an indicator? FFR, yeah, okay. So it's very rare. So 0.8 came of fame. I don't know, they may ask you defer. That was a very original study. For that, it had to be less than 0.75, okay? But then these studies are telling that. Going to the imaging, there are two kinds of imaging modality, which is what? IVUS and OCT, right? So IVUS is what? Ultrasound, and OCT is light. So very simple, black and white and color TV. You see that? You see a big difference. So resolution is 100 to 200 micron, whereas 10 to 15 micron. That's why you are able to see. Look at the picture; it's so clear. And most of the time, IVUS used to be 0.5 to 1 millimeter. So Boston recently came out with a new IVUS catheter called Avigo, which can do 8 millimeters per second. So it's fast pullback. But look at the pullback of the OCT. Okay. Is almost 36 millimeters per second. Very fast. Yeah. Only issue with the OCT is what? You got to clear the dye. So you only have to clear the blood. You should only see the dye. There are systems where you can use saline and all that. They still have a lot of side effects and complications because when you're injecting so much saline, there's a risk of patient going into VFib. So either of that is okay. The only issue with the OCT is what? One, if your creatinine is high because you're giving a lot of dye, and other thing is for proximal lesions like left main, osteal lesions, you're not able to evaluate well. That way even IVUS could be a trouble because you need to be coaxial to get a good imaging of the IVUS. If your ostial and your catheter is just above, you may not get a good thing. So what is the important thing about OCT is to understand the fibrous cap. You cannot calculate the fibrous cap thickness where all thing about vulnerable plaque and TICFA, all that discussion is only when you have to do OCT and you can calculate the fibrous cap. And also calcium, okay? Management of calcium. IVUS can tell you, yes, there is calcium and the degree of calcium, what is the circumference and the length, but it can never give you the depth. Depth is important. So you have to remember that it's not possible with this. So higher resolution, and you can define calcium nodule, which is also again a new thing, ISR. So you know what are the three layers, right? Intima, media, adventitia. So after intima, you see a thin, like a black line, okay? And then becomes the adventitia. And look at how you see it well on the OCT, intima, media, adventitia. So you have fibrous cap, then there is a soft echolucent signal of the, if you see that, soft plaque, calcified. Why you know it's calcified? You don't see acoustic shadow, you don't see the ultrasound going behind. So when you see that thick white line like that, is that, but see the difference here. Like I told you, you can see exactly the borders, nice borders in the OCT. You cannot see that in the IVUS. That's why it's better off. And fibroathyroma, and you are able to the thin cap. You see the cap, you are able to measure in B. A, very thick fibrous cap. They can give you some pictures and analyze, okay? Other thing is also, I'm not sure if you have to download all the apps that we have. All these images are there with the nice explanation. So calcium assessment, like I said, arc. So you make 4 quadrants, right? 90, 90. Anything above more than 180 becomes severe. Same thing, you look at the OCT, you can get the thickness. This is calcium nodule. You see that, it protruding. Look at the big difference, the OCT and here, how you can see the difference. Because management of calcium nodule is something little different where you have to do atherectomy plus minus IVL and all that. There will be a lot of discussion happening. So remember the rule of 5. This rule of 5 can only happen, I think, if you are doing the OCT. So what's the rule of 5? Angle, what? More than 180. More than 2 quadrants. Thickness, right? 0.5 millimeter, where you can only calculate with OCT, and the length also 5 millimeter. So they give the score. And based on that, you can say. So this is what came out. This is all often discussed. You'll see during live cases, as well as management of the patients, that this is often discussed, and remember that. So match the plaque here. A is what? Good. B? Or calcium, no. Look at the whole thing, right? You see it, right? And other one is thick fibrous. Huh? They are all matched actually. Soft, A to A, B to B, calcified, fibrocalcific, and C fibrous. Okay, good. Which of the following most likely to be vulnerable plaque? Huh? How can be A? Calcium.
B because it has got macrophages and other.
Yes. How do you differentiate macrophage? Because it is bright. Yeah, so likely B. See that? So what is the thickness? Anything less than 65 micron is a TICFA, okay? Thin cap fibroathyroma. Remember that number. That number may come up. So this was a thick cap, 120. This is often discussed. Questions may come. How do you do stent sizing, right? So what has happened is both in the current OCT as well as the newer IVUS catheter, This AI algorithm, it gives you the number in the side. So always remember normal to normal stent length. And diameter is where? Suppose you have normal looking vessel, you can consider EL to EL. If it's not normal, you just take your, I would say the tightest area and go to the nearest. So if your tightest area diameter is like 2.75, then put a 3/0 stent. Like go to the nearest point. 0.75 means to the nearest. So if it's 3.25, make 3/0. 3.75, maybe 4/0, round to the nearest. And sometimes you're not sure, go to the distal reference, okay? Not the proximal reference. Distal reference, because proximal you can always post dilate. So that's how you can get the number. How do you know you did a good job after you stented? Look for the MSA. Okay, IVUS is what? 5.5, no matter what the vessel is, except left main, right? This is non-left main, 5.5, whether it is LAD, circumflex or RCA. OCT is 4.5 is acceptable, okay? That's how you do that. And for left main, more than 8. Remember these numbers? That could come into the question. They'll put some question and then they'll say imaging was done. Is it acceptable or not? Okay? Now, what are the imaging guidelines? Imaging guidelines are very important. Pre-lesion assessment, which is plaque morphology, stenting size, landing zone. Post is what? Very important is stent expansion and apposition. Because stent expansion is your MSA. If your MSA is less, you got to go and post dilate to bring it to your MSA of 5.5. And same thing in both the guidelines, it is class 2A. So these trials have been ongoing and we may get more data coming out. So this was for the Renovate Complex PCI, IVUS guided or angio guided. What did we see? IVUS guided imaging had a significant lower mortality, right? This was presented during the, and imaging guided PCI stent optimization was way better than the angiography guided. So that is why I think it is going to maybe 1 or 2 more where we are seeing that there's a mortality benefit. That is why now even the guidelines right now is 2A but may become more than that. Okay, which of the following parameter is not measured to report the extent of coronary atherosclerosis using IVUS? Yeah. Fibrous cap thickness. He said that OCT is the one you need for fibrous cap thickness. History of mitral valve prolapse, chest pain, ST elevation, 33-year-old. Which image? Huh? Yeah, what is it? Yeah. Now, there also you have to know white thrombus or red thrombus, which you don't have, but you can see it on the app. We say it, whether it's platelet rich or non-platelet rich. So it is B because it is thrombus. This is a stent, right? Malopposed stent. You see that stent? And that is what? ISR. Yeah. D is just a tight fibrous lesion. So it's B, red thrombus. So red thrombus is what? Plaque rupture or erosion. So these are all the apps. Go to the QR code. Everybody take the QR code. So we have the device which is released today. Angio 3D will be to understand how to do diagnostic cath simulator. And co-apt risk score is to understand who should be getting a tier. When you're talking to the patients who have mostly mitral regurgitation, secondary mitral regurgitation, you can give a risk score and then talk to the patients about what they feel. Okay. So we have guide wire, we have Octade, you have for IVUS. There are a lot of images, and also many of them have quiz. IVUS has quiz, OCT has quiz, and Guide wire is very important for you guys who are going into fellowship to understand the various guide wires that we use in the lab, okay? Any questions on this one before I move on to the second topic? Right? Any questions? We move on then. Where's the second one? Can we get on the second slide? Second talk. Yes. This is more of indication for TAVR and mitral clip. So we know we have 4 valves, right? Aortic, pulmonic, tricuspid. So pulmonic actually was the first one that came into existence because of the pediatric kids were getting it. So melody valve was the first valve that was approved. Then of course became the aortic. Then the mitral was the clip, and now we have other valves that are ongoing for the mitral. And then the tricuspid was the clip. And then we have the evoke, the valve that was recently approved this year. So this is where we are, but I'm talking on TAVR little bit and the mitral clip, okay? So if you see here, from 2010 onwards, several trials have been going on. Initial was the partner, right? So how did we start aortic? We started with prohibitive risk because it was not easy to convince people, surgeons, that TAVR does really work. So we went for prohibitive risk patients where compared initially to medical therapy versus TAVR and said it was better. Then we went to high risk, intermediate risk. So when I talk risk, what is the risk they are talking about? So that was the partner trial was for Edward Sapien. Then this was the Medtronic core valve. So we have all this came also to the low risk. So the risk we are talking is the STS. So STS risk score, actually you can go online and look at the risk scores, essentially depending on the age, gender, and other comorbidities, which is EF, COPD, pulmonary pressures, they give you a risk score. So anything less than 3 is low risk, 3 to 8 is intermediate, and above 8 becomes high risk, 7 to 8. So we started with prohibitive, means they should not be getting it, from there all the way down. So we came up to the things. So much so, they finally have we have follow up to 5 years, 4 years of low risk, and that they are equal to surgery. So even low risk patient means you are taking low risk people and they all are TAVR. So TAVR has become the standard of care. And very important, what you need to do is the same 8 major randomized efficacy of TAVR being non-inferior to SAVR for death and stroke in various STS risks, severe aortic stenosis patient. Many of them showed superior and safer outcomes to SAVR. So only one trial, partner 1A, which they may ask, remember that, okay, partner 1A, had a stroke higher in TAVR. Sometimes they like to ask one of these odd trials. So it is now what? Standard of care. So now you talk who should be getting SAVR, not who should be getting TAVR. Everybody should be TAVR, but who should be getting SAVR? So this is what I was talking about: low risk, intermediate, and prohibitive extreme risk. Okay, but now we only talk to less than 3, more than 3. Less than 3 is low risk, more than 3 is high risk. So how do you manage the patient with aortic stenosis? If you see a patient in your office or somebody referred to you or in the hospital, so how do you say it's severe? Severity is based on mean gradient of more than 40 or 4 meters per second. So that is how it goes. and then depends on the EF. So if all of them should be getting green is what all should be getting TAVR. There are sometimes questionable cases, especially if you have low gradient and low EF, you got to prove that is aortic stenosis is the reason for doing the surgery. Should everybody get TAVR? Remember I said yes, but at what age? For us, okay, it is 65, and then you see that the age is a little different in US versus outside. In America is 65. Anybody less than 65 are the people you have to consider for SAVR. That age could be given. So if their question could be 55-year-old that is having severe aortic stenosis, that should TAVR because, so age for America is 65 and Europe is 75. Otherwise, so here it's very simple, right? Age 65 should get SAVR. 65 to 80 we are saying plus minus, where a shared decision. Most often everybody will go for a TAVR, and about 80, 100% TAVR. What are the factors? Important that you need to remember, because this can be incorporated in your questions, which is age, risk. I told you the surgical risk, which is important. What nobody has discussed and it is not part of STS is frailty. So frailty is an important. What is frailty means? Is the patient wheelchair bound, unable to walk out of the house, cannot do daily living activities. All that is very important. And if the frailty is there, more likely favor for TAVR. Means patient can do little activity within the house, cannot go outside the house. And if somebody's family says no, can you do procedure? Then it has to be TAVR. Then there is also what's called as valve morphology, that bicuspid versus tricuspid, because bicuspid still to this day again should be we think should be, because it will be lower age and often the morphology is not favorable for TAVR because it's calcified, the raphe sometimes don't open, paravalvular leak, all these things are there. Concomitant other than access, 90% should get femoral access. Alternative access are there, which could be carotid, okay, and some people do the other access, but should not be considered. If the patient may be 70-year-old but has concomitant severe coronary artery disease, 3-vessel left main, should go for surgery bypass rather than doing PCI and valve. And other important is here, endocarditis. Patient has septal hypertrophy because of aortic stenosis, ascending aneurysm, all these other concomitant things you can consider should get first SAVR. But there are other things. Patient could be 70, had lymphoma, radiation, calcium of the ascending aorta. Those kind of patients should be considered for TAVR. So this is an important slide, and remember all the factors there. A concomitant other diseases should go for, like if you have AS and then moderate to severe MR, or AS and moderate primary TR, which is rare, but if you have it, consider AVR and maybe tricuspid ring, those kind of things. Just to give you an example, 2023, we are closer, look at the number of procedure wise, we are closer to 1 million TAVRs, and surgical volume definitely is going down when it goes to that. So when you're doing pre-TAVR assessment, okay, I don't think they will show you CT scan, but remember, because they can show you annulus and presence of calcium. If there's a lot of calcium like the other side, and they can ask the height of the left main. So it has to be more than 10. Okay, if it is low height, again consider a surgery in the patients. But there are ways to do procedure when there's low height and all that. I think that becomes too technical, may not be asked for the so this is the important other approaches. Remember I said has to be femoral. The other approaches, when it first started, was transapical, then became subclavian. Rarely people are doing transcaval, but maybe transcarotid. So other things that you need to remember will be subclavian, carotid, transcaval. The rest are out. Nobody does apical and should not be done. So is TAVR like very safe procedure? Patients come ask you, or they can ask you these questions. What are the complications that you see? The most important is what? Paravalvular leak. Paravalvular leak is related to calcium around the valve. Stroke. Stroke is about 2%, so remember that. Okay. Of course, bleeding is there for everybody. What is the need for the pacemaker? About 10% and more so with the self-expanding valve. So I'll tell you which are the valves that are available. So these are all the valves that are out there, and of these, which are FDA approved and available in America. Sapien came out first, balloon expandable valve. Then is a self-expanding valve, which is Evolute, nitinol mesh. Navitor is between the two. You see that? Sapien plus Evolute became Navitor. Yeah. So these are the three that are FDA approved, available in America. Like we showed, of course, there are a lot of other valves that are out there. Some are here, some are, outside. So for the Evolute, which is a big cage, it's a nitinol cage, and self-expanding means even after you place it, keeps expanding for the first 24, 48 hours. There's a risk of pacemaker higher there. Okay. Who should benefit from BV versus SCV? So younger age, CAD, PVD, all these things, all you can look at it. Very important is that easier coronary access when you have balloon expandable valve. This is just experience, easy access compared to the self-expanding. That's the way it is. So we said that who beyond severe AS for TAVR, other patients are, what are the other things that are ongoing will be when they are, like I mentioned, age less than 65, asymptomatic patients. Should asymptomatic patient get TAVR? We're not sure. Moderate aortic stenosis get TAVR? Not sure. Valve in valve and aortic regurgitation. So aortic regurgitation also, there's ongoing trial. So this is the trial that is ongoing. This actually was the case that was of a few patients that was presented last year, saying that it's non-inferior for that valve. This is another question that could come. What is lifetime management? So if you take a patient between 65 to 80, what will you tell the patient when they first come? So you can consider TAVR versus SAVR. You have a 68-year-old. What will you tell the patient? Should you go for TAVR versus SAVR? So there's always a discussion that you could say do SAVR now, then go TAVR and then TAVR. Because if you do TAVR now, it's very rare. They say explant surgery is very, very difficult and hard, and mortality for TAVR explant could be up to 15%. So very important, why heart team discussion? Okay, why you need a heart team discussion in this group of patients? Which is true about balloon expandable and self-expandable valve for TAVR. Which one? Good. 75-year-old female, progressive shortness of breath, P gradient 4.2, no AR, normal LV, no CAD. Risk of a stroke is higher with TAVR. True. Which is the wrong? Results from randomized controlled trial for TAVR in patients at low risk for surgery after 1 year have not been reported. Huh? Yes or no? They have been reported, right? Now, repeat hospitalization lower in TAVR versus SAVR. Everything is true except that. Following statement is true regarding the incidence of stroke. Okay. The one thing I did not discuss was this one. Embolic protection have been shown to reduce. Has it been shown? Rate. That is true, right? We said less than 2%. Yeah. Now, other app that I wanted to show you is how to engage if you have a TAVR. This is very important. You watch this animation, okay? Very, very important, because if how to engage, because this is not easy, engagement of the coronary arteries after the valve. Get the conclusion. So quickly I'll go through the mitral valve because the next person is waiting. So same thing, mitral regurgitation. Who surgery is not done. Almost 50% only get surgery. A lot of people out there who don't get surgery. So what kind of a regurgitation is there? Primary, which is degenerating. So it is 40, 32 to 65. So you can remember 40, 60%. Okay. So secondary functional is how? That LV dilates, annulus dilates, and then this is what happens. So very important is management of mitral regurgitation. When you see a patient, clinical examination, then you do echocardiography. When you do echocardiography, you'll define whether it's primary or secondary. Then primary only if it is high risk. Okay, patients can get clip. Everybody else should get surgery, primary. Secondary, you have to make sure patient is on GDMT. And remember that GDMT, the fantastic four. Patients have to be on this medication. On this medication, patient has MR and symptoms, then only you can go for the clip. It's very easy to get to that route. And they also put that they should get a. So transthoracic echo, people do in their offices, but which will define whether patient is a suitable candidate for clip is only when you do a TE, you understand the morphology. Primary, secondary, and what is the leaflet and how are you able to grasp the leaflet length and all that. So very important that you do that. So primary, like I said, treatment is surgery. Remember in the TAVR was very clear. Everybody TAVR. Here, primary, no matter what the age is, unless they're high risk, you go for surgery. But for secondary, this was approved 2013. But for secondary MR, it's a different mechanism where you can, if they have been given GDMT, because there's no GDMT for primary, you don't need anything. Often patient has severe MR, no symptoms, 62-year-old will go for surgery. Here you will have 80-year-old or 70-year-old, dilated LV, EF is 35, MR. Surgeons don't want to do that cases. Plus, there's no trial to say that secondary MR surgery will benefit. So they definitely, we should go for surgery, and that was approved in 2019 for secondary MR. Both the cases have to have, even in the TAVR, in the mitral, heart team discussion. Heart team discussion includes who? Intervention cardiologist, echocardiographer, and a surgeon. They got to be part, and collectively they will make a decision. Yes, this patient will benefit, and that is part of the guidelines. 2 trials, they will ask you over and over again, COAPT, MITRA-FR. COAPT was done in America, MITRA-FR done in Europe, and COAPT showed a benefit. MITRA-FR no benefit. Look at that. Both control group as well as patients who got the therapy, no difference. Why there was no difference between the two? Because in COAPT, they gave the therapy, and if patients were symptomatic on GDMT, they went for clip. Whereas in MITRA-FR, everyone went in, and they later on, they gave the therapy afterwards. So you have to have a good selection, that's one. And also your EF was way lower in mitral FR. So sometimes if your EF is really low, that you can say that it's a burnt out LV is not going to respond, and actually people did worse, and we also see that. So the 5-year coapt was presented again last year. And what did you see? Even at 5 years, you see a benefit. So you see that your benefit at the 1 year, and it continued even at 5 years. If you see that at 2 years, there was a crossover. And even with you, after you take the crossover of the treatment, later on, there was a similar benefit. It was a small group. It was only about 50 people or so who crossed over. But then they showed the benefit even over through 5 years. So essentially saying that if you have, they can give you a scenario, patient coming low EF, then, had been on treatment, what is the treatment of choice should be the therapy. Now, this is that risk score based on the paper. This was my previous fellow, Neeraj Shah. He's the one who took the co-opt paper from that, all the risk. And this paper was published, and we have created this app so that you can, it's just very simple click button. At the end, it will give you a risk of what that patient, benefit of that patient is, and you can also actually print out as a PDF and place it in the patient's chart. This is very important when you see these patients in their office to explain what is the benefit of death and survival without heart failure when they come up. So what is this other trial that the clip that I was talking initially was one kind of a clip by Abbott, but then there was another clip also that came out that is also there. These are all the various trial where it compared. Edward Sapien had their own new clip. They compared and said that they are better. These are the two trials ongoing. They, I think, likely will not ask. This is comparing clip to what? Surgery now. Okay, we have reached to that level that we are comparing clip to surgery, saying it's non-inferior, and all groups are included here. And look at the risk, more than anybody more than 2, means including even the low risk patients. Which of the following is true about co-opt 5-year? Control group patient who received mitral clip after 2 years had a similar outcome. That's true, right? Hospitalization was higher. D. Everything else is false, right? Which of the following factor is not included in the co-opt risk score? Residual mitral gradient. That is not included. We don't care what is the residual mitral gradient. This is just a randomized, essentially saying you can do both of them. And now we have to wait for the randomized control trial to come into existence. Okay? Now, any questions for this one? I saw Dr.